it's been 18 months since Namibia recorded its first COVID-19 case. And I must say, it's been a roller coaster since. A number of deaths and 3 waves in. We now have to live off Zoom meetings and sanitizers. So it's safe to say the new normal is definitely here. But there is hope. Obviously not in arm's reach, but there's sort of a visible light towards the end of the tunnel in the form of vaccines. Now, according to research, if about 60 to 70% of our population is vaccinated, herd immunity is reached. There has, however, been a strong wave of vaccine hesitancy impeding the world as a whole to achieve it. Welcome to the COVID-19 podcast. This is a podcast where we talk anything and everything COVID-19, as well as debunk myths related to the pandemic. I am your host, John-Colin Namene, and I'm joined by researcher at Survey Warehouse, Christie Keulder. Hi, Christie. How's it?
Good morning. I'm good, thanks. How are you?
No, very, very well. Now, in your latest column, you talk about vaccine hesitancy in SADC. I think we have spoken about vaccine hesitancy before, if I'm not mistaken. But you are now just bringing it to a regional area, I guess. Within your column, you talk about 5 determinants that vaccine hesitancy has, I guess. You call it, or it's called the 5C model, if I'm not mistaken. Can you perhaps just run us down that model?
Yes. There's been various studies internationally about this issue. And what we wanted to do with this column is to focus on vaccines, but in a regional context that would allow us to benchmark where we are in our process of vaccinating the population. And then at the same time, try and look for perhaps ways or countries that we may be able to learn something from, because as you will see later on, there's quite big variance within SADC with regard to this. Mm-hmm. So one of the models that is being used to try and understand vaccine hesitance is a model that is derived from studies done in high-income countries. This so-called 5C model that says vaccine hesitancy is measured at the individual level. So that's very important. It's how individuals feel.
Yeah.
And it has to do with confidence, the first C, in the vaccine, in the safety of the vaccine, in the system that administers it, and so forth. Complacency, that kind of argument that says, I won't be affected, my company won't be affected, my family won't be affected, there will be a chance later on for me to do this. Convenience, how costly is it to get to a vaccination point? If it's very convenient, with low costs, people are more likely to get vaccinated. Yeah. If the cost of getting vaccinated is high, there's a lot of constraints or inconveniences attached to it. The issue of risk calculation, how much at risk am I or my family of getting COVID, getting sick, perhaps dying? So if we see our risk as low, chances are that we won't sort of immediately go to get vaccinated. And then the issue of collective responsibility, which is a key issue, which we see. Basically what it means is that it's a notion almost of citizenry, where you see it as the right thing to do, not just to protect yourself or your immediate family, but also, your community or your clients or your nation, these entities bigger than yourself. And then, there's been of late, and it's nowhere near as much vaccination or vaccine hesitancy studies being done elsewhere, in the poorer parts of the world. But there are certainly studies now coming from, for example, South Africa, that says it's not as simple as the 5C models would have it. There are different factors which we need to investigate.
What are those different factors?
Well, again, this is not an exhaustive list, but there's sort of an interesting argument coming from some of the scholars that says it has to do with the fact for some members of the population, the South African population, it has to do with what they call sort of new liberal notions of health and health-related risks. Yeah. And that is that the risk and health matters are assessed on an individual basis. The rights of the individual, individual choices, individual responsibilities are emphasized over collective ones. So it fits with that 5C kind of model that says, if I'm not at risk, I won't do anything. If my family is not at risk, I won't get vaccinated. So we emphasize the issue of individual when it comes to making these decisions. And again, the collective entity, the nation, the community, the town, the whatever bigger social entity doesn't come into it. And then a second argument, which I think one needs to investigate because it shows a lot of explanatory potential, is the issue of social exclusion. A great many poor people are not included in the daily activities of the state. They don't receive clean water, they don't receive sanitation services, they don't receive land or housing or any of those things. So that kind of deprivation, that kind of neglect, if you like, causes trust relationships with the government to be eroded. And so governments that call on these communities, these socially excluded members of our nation, to step up to be vaccinated, they simply don't trust the government because they've been
excluded in any case,
disappointed and excluded for so much that why would they now sort of become part of something if they are not sort of properly looked after? And that, I think, is a really interesting explanation, which may offer a lot of explanatory value to vaccine hesitancy in poorer countries. So it deviates from the 5C kind of model in some ways. And what we see in Namibia, for example, is that the nature of trust in government over time has changed, and it's continuing to change. Where people in the beginning, say, the 1990s after independence, people were very trustful of government. They have now become very skeptical of government, So this may be one of the reasons why the Namibian population has been reluctant to get vaccinated. Or some parts of that.
I want to quickly just touch on the issue of social exclusion a bit, hey? I don't know, as you were speaking, I just started thinking, do you think that there will be some form of othering, some form of further social exclusion to people who aren't vaccinated if and when we do reach herd immunity? Since exclusion seems like a traditional practice anyway in Namibia, never mind other countries, do you think that other Namibians or some form of government othering or exclusion will come from a certain section of society not being vaccinated?
Well, these are the issues which are now coming to the fore, the kinds of debates that are now going on. As an employee, for example, you are expected to provide a safe working environment. If one of your employees refusing to get vaccinated pitches up in work with COVID, is it still your responsibility to send that person home if he or she doesn't proclaim their status, in order to protect your customers or to protect your fellow workers? Is it then fair to say that my worker can ask me that if you want to work, and because you're working with customers, you have to be vaccinated, right? And there are all kinds of examples where this is now happening. I've seen recently a media reports where members of a tour company said that since the tour guides that they have were not vaccinated, clients canceled their tour, right? So there are all these kinds of things which are happening, which may have consequences for those who are not vaccinated, despite it being your own free will to do that. I think both of these arguments around vaccination, though, tends to highlight the shortcomings of having a very individualized view of health and public health specific, so that it's not just about us and the choices we make, but the choices we make has an impact on some larger entity. And I think that's where we need to go. We need to understand that for tourism as a sector to recover, all Namibians need to go to be vaccinated. For the same as that tour company is asking its employees to get vaccinated in order to be able to receive guests. So, I think this very individualized notion is what seems to be hampering some segments of our population.
Yeah. Now, I mean, we've touched a lot on vaccine hesitancy, but and the factors contributing to people being hesitant to get vaccinated. But I saw in your column that you also do touch on sort of factors that can be a form of vaccine hesitancy factors, but I think you took it more into the root of the factors that motivate people to get vaccinated. Can you perhaps also just quickly run us down through that?
Well, the thing is, it's what we're trying to do is we've put up information, data that looks at vaccination rates among SADC countries. And by putting ourselves in that context, we're trying to sort of look at what can and who can we consult when it comes to how do you get people vaccinated. For example, in the Seychelles, 74% of the population has had one shot and 70% has had two shots, right? So in the technical sense, the Seychelles should have herd immunity already through vaccinations.
Yeah.
Right? The second country is Mauritius. Mauritius has 57% of people with one shot, or with one shot at least, and 45% of those, 45% in total has had two shots. So only 11% of their vaccinated people is still in need of a second shot. Very close to herd immunity, much closer than anybody else. The Comores have 20% vaccinated with at least one shot, and then it goes down, right? Namibia is, so what we see is Namibia is somewhere just above the African average. 4.4% of the African population is vaccinated. We're at 7.4%. The gap between the island states of Seychelles, Mauritius, and Comores and the rest of Africa is significant. I think South Africa, being the biggest economy, we're at the biggest capacity, if you like, is out-vaccinated by Zimbabwe, which is interesting, and of course the three island states. So what we're trying to see is there anything island states can teach us about how to get populations vaccinated? What is it about the populations of Seychelles, Mauritius, and Comores that makes them more open to be vaccinated? Also, what is it in the population of Zimbabwe, which is relatively a country that struggles economically? Zimbabwe, more than twice our vaccination rate. They've even outshone South Africa, right? So maybe we could learn something there. In terms of the size of the population, the island states have small populations, but so have Botswana, which is higher than Namibia, Eswatini, also higher than Namibia, and Namibia itself. I think when we look at these countries, we can actually identify the countries that could have some assistance in how to improve your vaccination rate. Seychelles is 70% higher than the average in Africa. That's huge, man.
That's crazy news, actually, come to think of it. For an island like Seychelles, out of all countries that you would have thought to be on top of the list, it is quite huge news. But it seems like we have run out of time, Christie. Really appreciate you coming forth and having this interesting conversation with me, as we usually do. This was vaccine hesitancy in SADC, and as mentioned by Christie Keulder earlier, Namibia has only 7.4% of their population vaccinated, and we need at least 60 to 70% to reach some form of herd immunity. I myself got my second dose on Wednesday, so I am part of that 7.4%. Oh no, I think part of a smaller percentage that have received their full vaccinations. Like we discussed earlier, it is an individual choice, but in order to get to some semblance of normality, I think vaccination, and by virtue of that, herd immunity is the only way we can do that. Christie, thanks so much for joining me.
You're welcome.
All right. Until next time, guys, this was the COVID-19 podcast, proudly brought to you by the Namibian newspaper and the Osisa project. My name is John-Colin Namene. Cheers.